Thanks, Becky. So as Becky said, my name is Whitney Long. I'm a criticalist at NVS, and tonight I'll be talking to you guys about small animal critical care procedures. Maybe. So this is just an outline of the topics that we'll go through. So we'll just kind of go ahead and jump right in. The first one is going to be on central venous catheter placement. So this is a picture of a triple lumen jugular catheter right here. And then this is one inserted, but this is the kit that we use, which is the Myla International kits. So some advantages to a central venous catheter over your traditional peripheral catheter are that it facilitates sampling of blood. So you don't have to poke the patient numerous times throughout the day. We use these most often for like our diabetic ketoacidosis patients, any patient that's getting multiple blood sugars or electrolyte checks, anything like that. The sampling lines can be super helpful in that. It's also helpful in our critically ill patients that need multiple medications that may not be compatible with one another. So if they're on a dextrose CRI, they're getting a lot of antibiotics, maybe they're on a pressor, it's helpful to have multiple lumens to use to deliver those medications. Anytime we're giving like a hyperosmolar solution, so if we need to go above 5% dextrose in our fluids, it's ideal to have that placed in a central vein rather than a peripheral vein to avoid extravasation of the medication and other complications. You can also administer total parenteral nutrition via your central venous catheters. It's not something we do commonly, but we will occasionally do like a partial parenteral nutrition through these catheters. So not full nutrition, but just like either IV lipids or like a procalamine amino acid solution, something like that. They can be left in for a longer time and they're less likely to be affected by the patient moving or anything like that. Some disadvantages are they are more expensive and it takes a little bit longer to place them. And they do need some light sedation, but other than that, they're great. Some relative contraindications would be like a coagulopathy. So we definitely would not want to place a catheter in a large vein for a patient that is at risk of bleeding. And then in patients where they're prone to forming blood clots, like PLE patients, IMHA, pancreatitis, those type of patients, it's kind of a risk versus benefit, but placing a catheter in a central vein does increase the risk of blood clot formation. So that's something to keep in mind. And then patients with head trauma as well, just anything that applies pressure to the jugular vein could increase intracranial pressure. So we want to use caution in those patients as well. So the supplies that you need, so we'll talk about jugular catheter placement and then a peripherally inserted central venous catheter or sampling line, PICC line. But for the jugular catheter, that's going to be the most ideal because it does allow the triple lumen, but it does take a little more time to place rather than the sampling line. But we'll talk about that one first. So I've listed all the supplies there. Like I said, I showed you a picture of earlier, the central line pack comes with the catheters that has the injection caps and everything like that that you need. So you really just need your heparinized saline flush, all of your scrub and clippers, bandaging material, and then of course your sterile gloves, suture materials, and a soft tape measure as well. So the first thing you want to do is sedate the patient. So depending on how sick the patient is, you may be able to get away with no sedation. That's pretty rare. You can try like light dose of butorphanol, like 0.1 to 0.2 mg per kg. Adding in midazolam can be helpful at the same dose, 0.1 to 0.2. Sometimes if they're not quite as sick, you may need to use a little bit of propofol or alfaxolone. It's also something, if you have a critically ill patient in surgery, you can go ahead and place the central line while they're under anesthesia. because then they're very still. So that's also something to consider, and is a really good time to place these catheters. Once your patient is sedated or anesthetized, you're going to place the patient in lateral recumbency, and you want the neck extended and the thoracic limbs pulled caudally. And then you want to measure with a soft measuring tape from the thoracic inlet to the heart. Then you're going to shave that area, scrub it, open your central line pack, put your gloves on. You're going to need a restrainer to occlude the vein and then drape the area. And then you're going to pre-measure the guide wire from the intended insertion site to about the 3rd or the 4th intercostal space. And you don't want the tip of the guide wire not going beyond that level. Then you want to flush the central line catheter with saline into each lumen and make sure they're clamped off. And then you want to re-occlude the vessel. Typically, we do use a scalpel blade to make a lateral incision into the skin. And then you're going to go in with the catheter just into the jugular vein at the 10 to 30 degree angle. Once you are in the catheter, then that's where you're going to start using this, what's called the Seldinger technique. So I've listed it out there, but basically you have your catheter in place. You want to insert the guide wire using the thumb notch and the advancer in through the catheter. Once that's in, you want to remove the jugular catheter. So now you just have your guide wire in the vein, and then you want to make sure that the wire is stabilized. They can they're very long, so they can kind of go everywhere. So you want to kind of be careful when you're retracting the wire, and it's a little awkward at first. So now you've just got your guide wire in the vein, and then you insert the plastic tissue dilator into the vessel. And that, you can kind of tint the skin to kind of get it in, hold it for a few seconds, and just kind of go slowly like that. And the point of that is to dilate the vessel so that you can insert the bigger lumen catheter. So while you're doing that, you want to make sure, you're never letting go of the guide wire, because that's what's actually in the catheter. So that's the main part there. Once the dilator has been in, you can remove that and then insert the actual triple lumen jugular catheter over the guide wire to the pre-measured length. And then you want to make sure that the guide wire is going through the brown port. And then once you're in there, you fully advance it into the vessel and then remove the guide wire. So then you want to aspirate your brown port and make sure that you're getting blood flowing easily into the syringe. And then you're going to flush each port with saline and then put your caps on your triple lumen. So once you're in place and you want to confirm placement, so take a lateral chest radiograph and then secure the catheter in place. Once it's secure, you want to place a sterile dressing over the insertion site. So we typically use a sterile gauze square or a tegaderm, and then do a light bandage. And then we'll tape the multiple lumen ports on top of the bandage for easier access. Once you're bandaged, you want to still make sure you can access the catheter, and then you label each port. So we typically do the brown port for blood samples, the white port for fluid with additives, and then your total or partial parenteral nutrition. And then your blue port can also be fluids. You also want to place a date on the central line so that everyone knows when it was placed. So here's a radiograph of this patient. Also has an NG tube in the stomach, but the central line is coming right just above the heart. So obviously you don't want to go too far into the heart. If it's kind of up between the first and second ribs, that's not as big of a deal, because we're typically not measuring like central venous pressures or anything like we used to. But that's kind of where an ideal placement would be. And this is just a picture of a bandaged central line with the ports kind of sticking out of it. So when you're obtaining a blood sample from a jugular catheter, you want to make sure that you stop all the fluids and the medications prior to sample collection. You want to wear gloves anytime you touch the catheter, and you're going to clean the blue port, the top of the brown lumen cap with an alcohol swab, and then flush the brown lumen Usually for dogs, we'll do about 1.5 mils of heparin saline and then aspirate a minimum of 3 mils to make sure that you're getting rid of all of your fluids or whatever is going in there. For cats and small dogs, about 1 mil and then a flush and then 2 mils of blood. Then you're going to take your actual sample, however many mils you need, and then flush back in the blood that you pulled out, and then flush the line with 3 mils of saline. So for the catheter itself, you want to change the bandage at least every 24 hours or more if needed. Light colored bandages are recommended because you can see if there's any like oozing or bleeding, anything like that. Whenever you do change the bandage, you want to be sure to replace the tegaderm, so the part that's touching the catheter. And then you can kind of gently clean around it with chlorhex and sterile saline. And you also want to be sure that you're examining the neck about every 6 hours or more often if needed to make sure there's no swelling. And then you want to flush the brown part of the central line at least every 6 hours, just so that there's no clots in there. You can actually leave these in place for up to a month, but I certainly wouldn't be like sending patients home with these or anything like that, but they could last that long in theory. So some potential complications, certainly inflammation or infection is common as with any catheter placement. The catheter, the line, or the dressing could become damaged or dislodged. The neck could swell, so that could indicate that the wrap is too tight. You can also get oozing at the catheter site. If you notice any swelling of the forelimb on the same side that the jugular catheter is placed, that could indicate like a thrombosis or something. So if that occurs, you want to pull the central line. And again, you can have other signs of thrombosis as well. So for the peripherally inserted central catheter, or also known as a PICC line, we commonly call them sampling line. Those, like I said, are a little bit faster to place, and they don't allow for, multiple ports to be giving lots of fluids through, but they still have the advantage of being able to aspirate blood samples from the catheter. So it's very helpful, again, with those patients that we're checking BGs on often. So the supplies needed is listed there. This, we use the drum kit, which I'll talk about. There's kind of 2 different versions of the sampling line, but they come in a pack with everything that you need. You just need to get your scrub and things like that, your heparinized flush, your bandage material, and your gloves. So this procedure, you want to shave around the hind limb. So we're going to be using saphenous vein. In these cases, it's typically a lateral saphenous vein, but you can also do a medial saphenous as well. You're going to scrub the area, open your sterile sampling line pack, put your gloves on, have someone include the vein. Again, you're going to go into the vein with the catheter just like normal. Once you get blood in the hub of the needle, you're going to hold the needle in place while you advance the catheter off the needle into the vein. And then once you get venous access, then you remove the needle and place the closed adapter on the end of a catheter. And then for the drum catheter system, which again is the one that we use most commonly, you're going to remove the cap and insert the male lure of the drum advancer into the IV catheter. And then you're going to advance the longer sampling line into the vein by turning the wheel clockwise. And then you keep going until you see the 3rd long black mark or until you meet resistance. And then you stop advancing, pop off the top of the drum, and then further advance the sampling line and then lure lock the 2 hubs together. So the short IV catheter is going to remain in place to facilitate the replacement of the long sampling line if needed. And then you're going to remove the stylet from the sampling line by twisting the plastic end and pulling out. The intracast system is just a different method, so we don't typically use that one, so I'm not going to go over it. But once the sampling line is in place, you want to place a T-port on the end, flush saline into the vein, and then aspirate to make sure that you get blood back. And then you're going to secure the catheter and sampling line in place, just as you would a regular catheter, and we do like to bandage those, leaving the toes exposed, taping the blue port on the outside of the bandage and labeling it just as you did for the central line catheter. So to use This sampling line, you like to get a sample from it. You want to wear gloves, clean the blue port with an alcohol swab, flush the sampling line with 1/2 ml of heparin saline, and aspirate back a minimum of 1 to 5 milliliters of a heparin blood mixture. Then you're going to aspirate your sample and then flush back in the 1 to 5 mils, and then flush again with heparin saline. So it's pretty similar to the central line. For the maintenance of these catheters, you want to change the bandage at least every 24 hours, more if needed, because they are in a hind limb. They do tend to get soiled more often. So that's just something to keep in mind. We can definitely see some infections if they do get contaminated with urine. You want to retape the catheter every 24 hours or more if needed. Again, kind of just cleaning with chlorhexidine and saline. You want to check the toes for swelling every 6 hours at least, and then flush it at least every 6 hours as well. But these can remain in place for about 2 weeks if the site remains clean. The complications are similar to your jugular catheter. So inflammation, infection, damage or dislodgement of the line, swelling of the neck, should say swelling of the limb, oozing at the catheter site, and thrombosis as well. So like I said, the sampling line and the central lines can be super helpful as far as, keeping our patients on all the medications we need. The next procedure we'll talk about are transfusions. So having a central line is super helpful in these cases. So that would allow them to get blood and fluids at the same time. But a lot of the times these patients are either coagulopathic or critically injured, so we don't have time to get a central line in them. So peripheral IV catheters are fine for transfusions as well. So we think about, our typical indications for transfusions. Anemic patients are the most common. So our IMHAs, acute blood loss from like trauma, hit by car, things like that. Hemoabdomens, bone marrow failure, coagulopathies, we see commonly for needing like plasma transfusions. So if you have a patient that needs a transfusion, component products like your packed red blood cells or your fresh frozen plasma purchased from a blood bank are going to be ideal. However, there is a blood bank shortage, so these are hard to get, even for us. So if you don't have the component products, and then in certain cases, whole blood can be transfused as well. So cases where transfusing whole blood would be beneficial would be things like acute blood loss from trauma. If you have a patient that's concurrently thrombocytopenic, we don't often transfuse platelets, but that is another component product. But typically, most of the platelet products do not have a lot of efficacy. The platelets kind of degenerate before you give them to the patient. So whole blood can be helpful. But it's, like I said, something that's not always readily available. So again, our commercial blood bank products, the main two that we're talking about are your packed red blood cells and your fresh frozen plasma. So your packed red blood cells are going to be for your anemic patients with a stable blood volume. So like your IMHA patients. And to get this, they basically take fresh whole blood from their donor dog, centrifuge it, and then remove the plasma portion. So the PCV of these packed red blood cells that you can purchase from a blood bank is about 50 to 70%. So it's a higher hematocrit than in your whole blood. And they typically last about 35 to 45 days. And the dose for those is 6 to 10 mils per kg over about 1 to 4 hours, depending on how sick the patient is. The fresh frozen plasma is going to be the other half of the packed red blood cells. So the other half of that whole blood after they've removed the packed reds is your plasma. So it's going to contain all of your clotting factors with some of your packed red blood cells, but not a lot. It is frozen, so it lasts for a year. So that's nice to keep in the freezer, especially in the hotter months when we need it a lot for our heat stroke patients. The dose is the same as for your packed red blood cells, 6 to 10 mils per kg over about 1 to 4 hours. So for our fresh whole blood transfusions, this are going to be what we're doing more frequently now that we can't get the stored blood products. So this is going to be use of our blood donor dogs. So again, it's going to be ideal for patients that are hypovolemic or have acute blood loss, and they're also going to need clotting factors or platelets, but those also don't transfuse well. So ideally, you want to use fresh whole blood basically as soon as you collect it from your donor, but you can store it for up to 24 hours. And the dose is going to be higher because the PCV is going to be lower. So we typically do 10 to 22 mils per kg over about 1 to 4 hours. So the important thing about whole blood is just that you can't just take a dog off the street and donate blood from it and then give it to another dog. Well, I mean, you can, but the main concern would be, are we going to transfuse an infectious disease when we do that, or things like that. So we have a blood donor program at NVS where we use employee dogs and cats, and we'll screen them annually. So our criteria, I just listed up here. So if they're dogs, we like for them to be between 1 and 7 years old, weighing more than 50 pounds. Then that's all the blood work that we run on them. IDEXX has a blood donor panel, and it's free for employees. So I'm sure a lot of you guys have that as well. And then we do a fecal sample as well, because that's not included. And then we'll, of course, blood type them. And then in cats, we like for them to be 1 to 10 years old, weighing more than 10 pounds. Again, there's a blood donor profile feline that we submit to IDEXX, as well as a heartworm test, blood type, and fecal. We like for the donors to be up to date on vaccines, on flea and tick and heartworm preventative, and just overall in good health, no underlying conditions or anything like that. So when we collect whole blood on these patients, this is the equipment that we need. So this is a blood donor bag for dogs. So it's also helpful to have a gram scale, hemostats to clamp the bloodline, your microplate bag spike, a blood collection bag, which is in the picture there. If you don't have a blood collection bag, so that already has your anticoagulant in it, you can kind of see the little bubbles. But you can make your own, or if you're just getting a small amount, like for cats, you can use a sterile syringe and then whatever anticoagulant you want to use. And then your sterile gloves and just regular exam gloves. So for dogs, we like if we need to use a blood donor for a patient, we'll call in the employee and then make sure, that dog gets examined, make sure they're healthy that day. We get vital signs of weight. We'll do a CBC and a chemistry panel on the patient in-house. And then if the results are normal, we go ahead. If a cross match is needed, then we'll perform that. So cross-matching in dogs is ideal, but not completely necessary unless they've had a transfusion before. A lot of times, if it's an IMHA patient, they are difficult to cross-match. But if you want to do a cross-match, you should definitely do that before you bleed the donor. So once everything is kind of in order, we've decided this is a good donor to bleed, then we'll sedate the patient. And depending on the dog, sometimes like Torb is all they need, or a little bit of ACE. Sometimes they need dexdomitor, things like that. Just want to get them in a nice plane of sedation. The patient should be placed in lateral recumbency. You want to clip a square over the jugular vein, sterilely prep that area, and then you want to place the blood collection bag on the gram scale. So 1 mil of blood is about equal to 1 gram. And so our goal for dogs is to collect about 450 mils of blood. Sometimes we can't always get that much, but that's our goal. So the next step, you're going to temporarily clamp the tubing to prevent air from entering the bag when the needle cap seal is broken. You want to have the assistant restrain the donor comfortably, take off the needle cap, and insert the needle to the blood collection bag into the jugular vein, and then blood should start flowing into the collection bag. When the blood is flowing in, you want to have an assistant rotate the bag intermittently during donation so that it's mixed properly. And then once you get the appropriate amount that you want, And then before you remove the needle, you want to make sure you clamp off the collection tubing that's proximal to the patient. And you remove the needle, place a light pressure wrap, and then label the unit with all the correct information, collection date, expiration date. And then afterwards, the donor dog usually gets the same amount of blood that they donated back in sub-Q fluid. So usually about half a liter of fluids after a donation. For cats, the process is similar, but we're just using a 60 ml syringe and just a regular over the needle IV catheter or a 19 gauge butterfly catheter and a stopcock. So for that, again, you're going to have the pet examined, the donor pet, and then cross match should be performed on all cats that are receiving blood products. If everything checks out, then you can proceed as normal, but basically you're just going to use the syringe and the butterfly or the regular IV catheter to collect the blood that way. So I've listed out the amount of anticoagulant to kind of prime your 60 ml syringe and your 3-way stopcock system with. So it's 6.25 mils of CPDA or 2.5 units of heparin. And for the heparin, you want to use the U100 syringes. So you just kind of coat that in your system. And then once you hit the jugular vein on the donor, the assistant will slowly draw back the blood into the system. And for cats, you want to take about 50 mils of blood. And then again, you're going to rotate the syringe as you're collecting the blood to make sure everything mixes properly. And then before you remove the needle from the jugular vein, you definitely want to close off the stopcock to the patient so that you're not adding air into the jugular vein. Once you do that, you can place your light wrap around the neck and then label the unit as you did for dogs. And then again, they're going to get the sub-Q fluids as well. So once you've collected your blood, well, actually, you probably do this before you collect your blood, but you want to make sure that you're giving the right blood type to the right patient. So for dogs, just a brief overview, there are 2 different blood types. There's DEA 1.1 negative and DEA 1.1 positive. So your negative blood can only be given or can be given to any dog. So if you have a negative donor, that's ideal. They can donate to any patient. If you have a positive dog, they can only donate to positive dogs. So we have both in our system, and sometimes we need just the positive dogs, but in a pinch, a negative dog can donate to anyone. In cats, they are much more at risk for hemolytic transfusion reactions if they get the wrong blood type. So there's type A and B and type AB, but the important thing is that a type B cat can never get type A blood or a fatal reaction could occur. So most of the cats around here are going to be type A. We've had a few type Bs come through. We do have a couple of blood banks. I think there's one in Atlanta that has a type B cat that they can call in to donate, but it's much more rare and usually takes longer to get the blood in for the type B cats. So once you've gotten the blood from the donor, you're now ready to give it to the patient that's needing it. So again, for the patient that needs the transfusion, you're going to blood type plus or minus cross match if needed, and then you need your unit. So again, for the dogs, it's going to be about 450 mils, and for the cats, 50 to 60 mils. And then you're going to either need a blood administration set or a hemonate filter, some type of monitoring sheet, a thermometer, and a fluid pump or a syringe pump. So again, prior to giving the blood, they're going to be blood typed, they're going to be cross-matched. Once you've done that, you can invert the whole blood bag 2 to 3 times to mix the blood, or if it's in a syringe, you can just rotate it back and forth. You're going to discontinue the fluids and give any critical medications needed prior to the transfusion, because you don't want to give any other fluids or medication through the IV catheter when a blood transfusion is in process. And so we'll typically give these over 4 hours. So, if they're needing antibiotics or something, you definitely want to get those in before the transfusion. Otherwise, you're going to have to push them back until the transfusion is over. So for the procedure, you want to always use a filter to remove any blood clots that have occurred. And then sometimes those will be like an inline filter, or you can use the syringe and the hemonate filter. It just depends on what you have available. But ideally, you should be wearing gloves when you're connecting the transfusion to the patient's catheter. If you're using a blood administration set, you want to fill the drip chamber about 80 to 90% full of the blood to prime the line. Then once the line is primed, then you just hook it up just like regular fluids and set it to the ordered rate. We typically do it over a fluid pump. For smaller volumes, you can kind of sterilely remove a certain amount from the bag into a syringe and save the rest for later, and use the hemonate filter as well. But you want to make sure that you are doing that sterilely. So wearing sterile gloves, using alcohol to wipe the port from the bag, and things like that. So like I said, we're going to give whole blood over 4 hours unless otherwise directed. And we'll typically start at a quarter of the goal infusion rate. So whatever we want to get up to, we'll start at a quarter of that. And then after 15 minutes, we'll recheck vitals. If everything looks good, then we'll increase it by a quarter. So then we would be at a half. And then you're going to recheck at 30 and 45. And then once you reach the 60-minute mark, you should be at your full rate that you're going at. And then we typically will check vitals every 30 minutes until the transfusion is done. So obviously that can be tedious, requires dedicated nurse time, but it is very important because you can really catch early signs of a transfusion reaction in those first kind of 15, 30 minutes of starting the infusion. Sometimes that we would give the blood quicker would be, if they're hypotensive, if they're in surgery, or if they're crashing. Sometimes we'll give it over an hour, over 2 hours. Very rarely do we slam the whole bag unless it's like a CPR type situation. Once the transfusion is over, you want to add enough saline to the bag. This is if you're using the administration set and the collection bag to kind of flush the line through. If you're using the syringe pump, you want to follow the transfusion with the amount of saline needed to flush the line. So you just want to get everything through. And then typically we'll recheck a PCV about 2 hours after the transfusion is over. So again, the monitoring is going to be very important. So every 15 minutes for the first hour of the transfusion, and then at least every 30 minutes until the transfusion is over. So some things to look for that would be, potentially an early sign of a transfusion reaction, but not enough to make us stop the entire transfusion itself, would be if the temperature increases by 0.2 degrees. So that's pretty subtle and pretty common. If their respiratory rate and effort is increased, if their pulse quality declines, or if they have any sort of change in heart rate. If that occurs, instead of increasing to the next rate, the next 15 minutes, you would want to hold there or potentially lower back to a slower rate. If the problem persists, then you may actually have to stop the transfusion. But a lot of times, if you just slow down your progressive increase, things will correct out themselves. If you notice any swelling of the face or any other body part, if they develop hives, if they become acutely dull, if they start vomiting, or if they collapse, that's when you want to stop the transfusion right away and not restart it. So this is just a table of different immune reactions that we can see when we give transfusions, some clinical signs, how quickly they would occur, and then what we could do. So you can read the chart here, but you basically got your type 1 to type 4 immune complex development. Some of these are going to be seen within minutes to hours. Some of them are going to take weeks. Not all of them require stopping the transfusion, but some of them do. There are also non-immune transfusion reactions that can occur. So that would be things that occur due to hemolysis or physical damage from the blood. So that's why it's important to use the filter needle. You can get embolisms like air embolisms or clot formation as well. But the most common manifestation of a transfusion reaction is going to be a fever. So again, if it's just a mild increase in temperature, you can try and slow the transfusion. But if it's a major jump, or if you notice like vomiting, respiratory distress, things like that, then you want to stop the transfusion. So the next procedure we'll talk about is giving anti-venom. So kind of similar to the transfusions, but a little bit different. So snake venom contains several different proteins, enzymatic proteins that can cause like a local tissue injury and a vasculitis. There are other proteins present that can deplete fibrinogen and fibrin. So the result is that you have a friable clot that's formed, and this is what's known as a venom-induced coagulopathy. You can also see acute renal failure and neurotoxicity with certain snake species, but those aren't really common in this area. But administering antivenom is really the only way to treat this venom-induced coagulopathy. Giving plasma won't help. The only thing that will help is the antivenom. So it's typically most effective if given within 24 hours of a bite. So in addition to kind of acting on these proteins in the snake venom, they can also help decrease the swelling, minimize the pain, decrease temperature. And in some studies, it's been shown to reduce mortality by 36% in dogs. So there's several different types of antivenom on the market. There's the ACP, which is from Fort Dodge. There's a FAB AV, which is from Potherix. And then we're using the Antidote 3 Radler at the moment, which I think I have a picture up coming up, but that's one that you keep in the freezer. So it lasts a little bit longer, but they all kind of are made differently. Some are better for certain species, and it's kind of ever evolving. And it also depends on availability, because a lot of these will be reserved for people, obviously. And so we just kind of have to constantly be looking on the market for new antivenoms and what's going to be most effective to keep on our shelves that we're going to use up. So yeah, here's a picture of what we're using currently, which is the Radler Antidote 3 antivenom. So it's pretty simple to give. You just need the antivenom, which kind of looks like a bag of plasma, some gloves, and then it comes with a filtration system and then a catheter in your patient. So the dose is 1 vial or 1 bag, regardless of body size. You can give additional doses kind of as needed based on how severe the envenomation is, the size and the type of the snake, and the size of the patient. But typically, 1 dose is most of the time all that's needed. We're not in like some places like Florida or Arizona where they're using like multiple bags on patients. Typically 1 bag is enough. Sometimes we'll need 2. It's also quite expensive, so that can be a limiting factor as well. So the procedure, like I said, it's pretty simple. You just want to make sure the patient has a catheter. You want to warm the antivenom to body temperature using a warm water bath, ideally. You want to stop any other fluids or medications while you're giving it, and then you're going to attach it to the filtration system and then give it through the IV catheter. So you're going to go slowly at first over the first 10 minutes, monitor for signs of anaphylaxis like hypotension, respiratory distress, vomiting, diarrhea, hives, anything like that. And then if you don't see any of those signs, you can increase the rate, and you typically give it over 20 to 60 minutes. If you do see signs of anaphylaxis, you obviously want to stop the infusion and consider epinephrine administration. This is not something that we typically have to do. I know with some other types of antivenom, some people will, recommend like a test dose. We don't typically do that with the Radler antivenom. It's not something the company recommends either, but that is something that you could consider doing. It wouldn't hurt. So just like a blood transfusion, we're going to monitor vitals every 15 minutes. So it's only for an hour, so it's not like you're doing it for 4 hours. And then again, if you see signs of anaphylaxis, you want to stop the transfusion. Side effects are pretty rare. If anything, it's usually going to be just a mild type 1 hypersensitivity reaction, like a mild increase in temperature, something like that. And in a study that the company did of 1,200 doses, only 0.76% of patients had a reaction. So again, it's pretty uncommon. So the next procedure we'll talk about is nasogastric tube placement. So this is something that we do quite commonly in the ICU for patients that are not eating, patients that have a large volume of gastric fluid to prevent regurgitation, things like that. It's a nice way to give oral medications, but let's say a majority of our patients in the ICU who aren't eating will get a nasogastric tube at some point, kind of like a central line. This is a great thing to place in surgery while they're already under anesthesia before they wake up. It's much easier when they're fully sedated or fully anesthetized rather than just trying to sedate them and they're sneezing. So if you have a patient that's in surgery that you think might not eat afterwards, or you're just worried about regurgitation, you can definitely place it. If you don't need it later, you can just pull it. It's nice practice. So that would be something to look into as well. So again, the nasogastric tube is going to be a tube placed in the nasal cavity down to the stomach. So again, it's going to be a way to give enteral nutrition, so feeding the gut. It's also helpful if you have cases of like gastric dilation from like air or fluid. You can decompress the stomach that way. It's not really helpful for food because you're not going to get food up through the tube because it's pretty small. If you have a GD patient that's not stable for anesthesia or gastric intubation, you can try it, but it's not ideal for a GDV. Some contraindications would be like respiratory distress, food bloat, cats with aerophagia, coagulopathy, thrombocytopenia. Here are the materials that you would need. There's a chart there with just a guide for sizes to use. So we use the Myla nasogastric tubes. So the smallest size is a 6 French, and they go all the way up to a 12 French. So you need your tube, some suture, a 22 gauge needle, a marker, a graduated cylinder, a proparacaine, sterile lubricant, and your exam gloves. So what you want to do is you want to place several drops of proparacaine into both nostrils, measure the tube from the nasal meatus to the last rib, and then mark on the tube where you want it to go, and then also measure to the thoracic inlet. You're going to remove the stylet from the NG tube, apply some lubricant along the length of it, or you can just kind of flush through the tube as well, just to kind of make sure once you get it in that you can pull the stylet out, because that's happened before. Then you lubricate the tip of the tube with the sterile lubricant, grasp the patient's muzzle, and then insert the tube ventrally and medially into the nose. So there's a couple of tricks that you can try if it's not going in. You can try pig nosing them or pushing the nose upwards. Sometimes even flexing the neck can help. But once the tube is in the nostril, you want to point the patient's nose ventrally so that the chin is close to the thoracic inlet. So that helps it go into the esophagus. And then you want to go to the predetermined number where it's at the thoracic inlet and then take an x-ray at that point. Once you confirm that you're in the esophagus and not the trachea, then you continue to advance into the pre-measured length into the stomach. Then you want to take a final confirmation radiograph, remove your stylet, and then secure it into place. So we typically will do like a 22 gauge needle lateral to the nostril, pointing down, not towards their eye, and then just kind of feeding the suture through and doing a little finger trap right there. And then you also want to do another stay suture kind of back near the ear. So it's, you can also go up between their nose, just so that it's secured in 2 locations. Then you're going to aspirate fluid or air, whatever you get out of the stomach, with your syringe. So that's where the graduated cylinder comes in to measure that. And then definitely want to remember to put an e-collar on the patient so that the tube doesn't dislodge. So this is a radiograph just showing placement of a nasogastric tube. So you can see here in this first red circle, this tube is above the trachea in the esophagus. If you just look at this area, it's hard to tell is it in the trachea or the esophagus. And then here you can see it's in the stomach. So that's why we do the first x-ray where we look at the thoracic inlet just to make sure we're in the right spot. As we have definitely had a case where we were in the trachea and went into a bronchi and the patient developed a pneumothorax. So it can happen. And that's one reason, taking the extra radiograph of the thoracic inlet can be helpful. So again, that's like I said, that's an extreme complication. Not very common at all, but it does happen. A lot of times if you get it in the trachea, which is common to do, the patient will just cough or you won't get negative pressure, things like that, but you can go too far in and get it into a bronchi. So if you look at this x-ray, this is actually in the trachea all the way through. So if you just looked right here, you might think, oh yeah, it looks like it's in the stomach. So that's why it's important to look further up the neck there. Epistaxis is pretty common. It's usually mild and self-limiting. You can get some hemorrhage, especially if you hit one of the blood vessels in the nose. It can dislodge easily. It can become clogged. You can get aspiration pneumonia, especially if you're feeding and it's not in the right spot, or an esophageal stricture, I think would be very rare from an nasogastric tube placement. So typically these can be maintained in place for up to 7 days, and then you want to aspirate the tube about every 4 to 6 hours or more frequently if needed. So if there's constant regurg or you have a large volume of fluid in the stomach, you might need to aspirate it more frequently than that. If the patient is regurgitating and you're not getting negative or you're getting negative pressure, you might want to just recheck the radiograph and make sure it's still in the stomach. Sometimes it can pop out. That's in the esophagus. That's obviously not going to get any of the fluid out. So just kind of troubleshooting there. You can also give medications through the NG tube. Obviously, liquid medications are going to be ideal. Certain medications you can crush and give through the NG tube, but not all of them. So you definitely want to check and make sure the efficacy of the pill is not going to be lost if you give it through the tube. And then you can also do liquid feedings, which is what we typically do. You can do that as a CRI or as a bolus feeding. Typically for bolus feedings, we'll do those every 3 or 4 hours. And if the patient has prolonged anorexia, we'll start with a third or a quarter of their resting energy requirement over the first 24 hours, make sure they tolerate that, and then increase it daily by either a quarter or a third until they get to the full RER. The tube should be flushed with about 6 to 10 mils of warm water anytime medication or food is given. That's just to help prevent clogging of the tube. So the next procedure we'll talk about is a little more permanent than the NG tube, and that would be an esophagostomy tube. So this is something to consider in patients that you're not going to manage in hospital. So typically we will not send patients home with an NG tube. It seems it's much more easy for the patients to dislodge that at home. There's much more risk in, it's going into the trachea. So we typically don't send home NG tubes with patients. But if you did want to send a patient home that hasn't been eating, or maybe you want to, see them back frequently, an E-tube is also a great alternative. And the main difference would be it's more invasive and they do need to be under general anesthesia for an E-tube placement, and it is a little more permanent, although still a temporary thing that you can do. But it is nice for facilitating nutrition. And I think, obviously the most common reason for an esophagostomy tube would be like a hepatic lipidosis cat. So that's going to be kind of the poster child for an E-tube. But they can be useful for medium-term feeding, so 1 to 20 weeks. After that, you may need to either replace it or look into a different type of feeding tube. We will do these commonly in patients that have some type of head trauma or like a broken jaw from being hit by a car, the E-tube is nice just while their mouth is recovering, if they're recovering from any type of oral surgery as well. So again, the main thing is that they do require general anesthesia. Some contraindications would be vomiting, respiratory distress, megaesophagus, esophageal stricture, or any patient that has impaired wound healing. So some of the materials that you need, obviously you need your tube. So we typically use like an 8 to 14 French tube in cats and small dogs, and then a 14 to 20 French tube in medium to large dogs. You're also going to need a right angled or a curved forceps, so a Carmalt forceps, and then a 10 or 11 scalpel blade, suture material, marker, a plug for the end of the tube, and then bandaging material. So the procedure for esophagostomy tube placement, you're going to fully anesthetize the patient, have them intubated, place them in right lateral recumbency, and then you're going to measure the tube from the center of the neck to about the 8th or the 9th intercostal space, and then mark it with a marker. You're going to clip and prep the left side of the neck, and then insert the curved forceps into the esophagus. So typically like a mouth gag, although not in cats, or just like a roll of tape to help keep the mouth open. You're going to insert the forceps into the esophagus until about the midpoint in the cervical region, and then tint the skin with the forceps outward, and then make your incision over the tip of the forceps that you have kind of tinted the skin with, and then extend the incision through the subq tissues and into the wall of the esophagus. Then you place the tube through the hole that you just made with the blade, and then grasp the end with the forceps, and then you're going to pull the end of the tube with the forceps out of the mouth, and then the hard part is where you unclamp that and kind of turn it around. So you gently push the distal end caudally. So that's the tricky part, especially in cats because their mouths are small. But once you get it flipped around, it should pass easily the right direction going in towards the stomach. But you can also use the forceps to kind of direct it into the esophagus. Once the tube is in place, like I said, the proximal end will flip from caudal to cranial, and then you want to make sure that's inserted to about the 8th or 9th intercostal space or to your pre-measured mark. Again, you're going to confirm that you're in the right spot by radiographs, and then we'll typically do a loose purse string suture around the tube entrance site and then a finger trap to secure it into place. So here's a picture of an E-tube. So here you can see the patient is intubated in the trachea, and then the E-tube is extending right here until about the 8th or 9th intercostal space. So it's a very nice placement there. Some complications, you can have inadvertent tube placement into the trachea or into the space around the esophagus. The patient can vomit and they can vomit the tube up. The patient could remove the tube themselves. If the patient appears nauseous during feeding, that could indicate that the tube's in the wrong spot. So we need to take another x-ray and make sure it's in the right spot. The tube can become clogged. They can get a skin infection or a skin abscess at the E-tube site. Those are kind of the main complications there. For feeding through the esophagostomy tubes or the E-tubes, probably the most common thing to feed, especially in the beginning, especially if they're critically ill and still in the hospital, is going to be a mixture of Hill's AD and water. So typically it's 1 can of AD with 50 mils of water, and that equals about 1 kcal per mil. So other diets can also be used. You just may need to use more water. So you basically want the consistency to be kind of a gruel to where it will pass easily through the tube and not get clogged. It's helpful if you warm the food prior to feeding, and then once you do feed it, you kind of uncap the tube, check for negative pressure, flush with 5 to 10 mils of warm water, do your feeding. Typically we'll do those bolus feeding, and you do it slowly, and then after the feeding, flush another 5 to 10 mils of warm water. And that's again to prevent clogging. of the tube. When you're feeding the patient, you want to make sure you're watching them closely. Do they look nauseous? Are they going to vomit? Things like that. And then once you're done feeding, close the tube, close the port of the tube so they don't ingest any air. Again, you can give medications through the tube. Liquid medications would be ideal, but you can give some oral, like pills crushed up. For care of the stoma site, you want to use gloves anytime you're handling the E-tube, and you want to keep it as clean and dry as possible. Again, looking for signs of inflammation or infection, redness, swelling, heat, things like that. If the site does require cleaning, use sterile saline or a very dilute chlorhexidine solution. You don't want to go crazy scrubbing it or anything like that. Typically, we'll cover the site with a sterile, like a Telfa pad or a Primapore, and then wrap a light bandage around that. For the cats, I can't remember what they're called, but they're like little kitty E-tube bandages that internal medicine uses a lot. So you typically just do like a Telfa and then that pre-made bandage. You don't want to use triple antibiotic in that area because it just makes things extra moist, and then that can promote bacterial growth. If the tube distance is labeled or marked on the tube, then you want to kind of check and see, is it still the same site? Sometimes that permanent marker can wear off though, and it can be hard to tell. You want to also look for leakage of food or other fluid around the site. And then once the patient is discharged, you want to look at the E-tube site at least once a week and change the bandage once a week at your follow-up visits. So the tube can be removed whenever the patient has overcome whatever disease process it has. So their blood work is looking better, or it's normal, and they're eating an appropriate amount. So once they start eating on their own, we'll typically start reducing the calories by 25 to 35% a week. And then totally remove the tube once they're eating about 75 to 100% of their calories. So we'll move on to the next procedure, which is a thoracocentesis. So this would be something that's more on the emergency side of critical care, but definitely can develop in hospitalized patients, and is a very common procedure that we do in emergency and critical care. So the indications would be pleural effusion or a pneumothorax. If it's a life-threatening situation, there's no real contraindication to a thoracocentesis. A coagulopathy might be like a relative contraindication, but if it's the patient is in danger, then you should go ahead with the procedure. So the materials are listed there. There's a couple different methods depending on the size of the patient and just clinician preference. But you can use a butterfly catheter, a needle, or an over-the-needle catheter. Typically, we'll set up with an extension set and a three-way stopcock, syringes, a collection bowl, collection tubing, and then as needed, an IV catheter, some sedation, a local block, all things that are ideal, but sometimes in emergency situations, you might not have time for any or all of those. So you can use sedation if needed, providing flow by oxygen is needed. So just trying to stabilize the patient as much as possible before the procedure. The patient can really be in any position. I typically like sternal recumbency, or if it's a big dog, standing. Lateral recumbency can be helpful for pneumothorax, and usually the patient's more comfortable in lateral recumbency. But then you want to clip and prep the appropriate rib space. So that depends on what you're trying to aspirate. So if you're aspirating fluid, you want to go to the 7th or 8th intercostal space ventrally, so at the costochondral junction. If you're looking for air, around the same area, or the 8th to 9th space dorsally, so about a third of the way up the chest. But you want to use a local block if desired. Sometimes there's not time for that, often not necessary. Then you put your sterile gloves on, and then you can either do an over the needle catheter technique or a butterfly needle catheter technique. So for the butterfly or the needle technique, you want to attach your butterfly or your needle to a 3-way stopcock and a syringe. Turn the stopcock off to the patient and then break the syringe seal by aspirating air. Then you want to insert the needle through the skin. So you want to go perpendicular to the chest wall, and then you want to go cranial to the rib to avoid the intercostal vessels. And then you're going to go into the pleural space. So once you're through the chest wall and into the pleural space, you can direct your needle up for air or down for fluid so that the needle is kind of like parallel to the chest wall. So it's not just sticking straight into the chest where it's more at risk for lungs hitting it. So you either want to go down or up the chest wall with the bevel facing away from the chest wall so that you actually get something. If you have the bevel the wrong way, then you're not going to get anything because it's just going to be up against the chest wall. Then you want to aspirate slowly and then stop once you get negative pressure, get blood, or if you feel the lung scratching against the needle, which is a very unpleasant feeling. You can redirect the needle as you need to kind of continue to remove fluid. And then if you do have the needle still on, the benefit of that is if you do get negative pressure, you can kind of push the fluid back in to break off any clots or something like that. Whereas if you don't have the needle in, then that's... You can also save the fluid if you're getting fluid and not air for like fluid analysis, cytology, or culture. And then if you're getting air, then you want to continue aspirating until you get negative pressure or hook them up to a continuous suction system. So here's some pictures of the butterfly needle technique. This is they're getting air here. The pet's in lateral, so there's nothing in the syringe. And then this would be a cat who's maybe in sternal recumbency. Looks like they're getting some chylus fluid back there. The over the needle technique is what I prefer for larger dogs. So it's basically just inserting a catheter into the pleural space. So you advance the catheter off the needle and then hook it up to your extension set. And then again, you're going to aspirate until you get negative pressure. So complications, obviously you can give them an iatrogenic pneumothorax. Typically if that happens, and it happens pretty commonly, it's usually mild. So it's not a huge deal. You can lacerate a lung. Again, not going to be anything major typically. There can be a little bit of hemorrhage. There's obviously a risk of infection. And then potentially a risk for re-expansion, pulmonary edema as the lungs reinflate, but that's not very common. So the next procedure we'll talk about is a pericardiocentesis. So again, typically more of an emergency procedure rather than critical care, but it's certainly life-saving. So indications for this would be a patient that's in tamponade. So these will typically be usually dogs that come in for collapse or syncope, generalized weakness, bounding pulses, can't really hear the heart. Maybe you have a flash ultrasound nearby and you see that the patient has pericardial effusion. So even if they're not in tamponade, you can use it as a diagnostic, but usually, unless it's a cat, we're going to be trying to remove the pericardial effusion. In cats, pericardial effusion is most often associated with heart failure and typically oxygen and Lasix, and you recheck it the next day and it will resolve. But in dogs, it's going to typically more likely to cause tamponade and systemic issues. So kind of like the thoracocentesis, there's no real contraindication, maybe a coagulopathy, but this is going to be life-threatening. So you're going to have the benefits outweigh the risks there. So prior to doing the pericardiocentesis, this is where I do always want to have an IV catheter in place in case you need to give lidocaine, which we'll talk about in a minute. Ideally, you're going to get your baseline blood work, saving some blood for a troponin level because that can help differentiate neoplastic from idiopathic causes. If they are in tamponade or the patient is in cardiogenic shock, some fluids prior to the procedure can be helpful, or even during the procedure. And then you want to have your emergency drugs on hand. So I usually will draw up a dose of lidocaine. Again, this is going to be dog, so 2 mg per kg, and just have it ready. And that's going to be if we note any VPCs. You want to place the patient on an ECG monitor and then sedate if needed. Usually they need sedation. Materials, you're going to use an over the needle, either 14 or 16 gauge catheter, a long catheter, or Mila does make a fenestrated long catheter. So I don't know if this is the fenestrated one, but here's a picture of one of the longer gauge needles. So they can be a little intimidating the first time you use one. Scalpel blade, 3-way stopcock, extension tubing, and your 12 to 16 cc syringes for aspirating the fluid, as well as just clippers and scrub. I also will draw up a lidocaine dose for your local block, and then of course your sedation. So for this procedure, I'll typically place them in left lateral recumbency. You can also do sternal recumbency. So for bulldogs, sometimes it's easier in sternal recumbency. I just like to be different. But the reason for that is, you want to be working on the right side of the heart because the coronary vessels are on the left side. So you don't want to lacerate those. So once the patient is in the right position, you want to make sure ECG is attached, and you're going to clip the right 3rd to 8th intercostal space from the sternum to just above the costochondral junction. Then you're going to give your lidocaine block, and you're going to choose a catheter that's going to be long enough to penetrate the pericardial sac based on the patient size. So typically a 5.5-inch catheter is what we're going to be using. So then once you're ready, you're going to make a stab incision with your 11 blade through the skin at the side of the catheter insertion, and then you're going to insert your catheter perpendicular to the skin, again going cranial to the rib. And then you slowly advance the catheter about 1 centimeter at a time until you see fluid in the hub. So I was taught to just aim towards the opposite shoulder, and that typically works. If you have an ultrasound machine, you can use that for guidance. But keep in mind, you're going to have to go further than you would for a thoracocentesis, and you can kind of feel it pop once you get into the pericardial space. And then when you do that, you're going to feed the catheter about another 1 to 1.5 centimeters, and then feed it off the top of the stylet. Then you're going to remove the stylet and attach the catheter to the extension tubing and your 3-way stopcock, and then your syringe. So while you're doing that, you want to monitor the ECG. So if you do hit the heart, which you may scratch up against the myocardium, it happens almost every time. You can see occasional VPCs. So that's why we like to have the lidocaine ready. If that does happen, you just back the needle out a little bit, give the lidocaine IV, and usually things are fine. If you do get fluid back, it's most likely going to be blood. There are other causes of pericardial effusion that may not be hemorrhagic, like certain infections can cause it. It's not nearly as common. It's usually going to be blood. You want to make sure that it doesn't clot. And then you could also compare the PCV of that peripheral blood you can compare the PCV of the pericardial effusion with the peripheral blood, and it should be about the same. And then you're going to gently suction as much fluid as you can. Sometimes you may get large volumes. If it's a chronic condition that's been going on for quite a while, they can build up a lot of fluid. If it's more acute, the fluid may not, you may not get as much fluid. And then sometimes you can actually just kind of lacerate the pericardial sac, and then you won't get very much fluid, but the pericardial effusion will kind of be less on your ultrasound, and then you've just basically created pleural effusion, which is still an issue, but not as life-threatening as the pericardial effusion. So here's some pictures. Again, the needle is quite large. It can be quite scary, which is why you just kind of go slow. And then here's some blood coming back. Must be a very small dog using a smaller catheter there. So some complications, like we mentioned, VPCs, you can lacerate a coronary artery, you can lacerate the lung, there could be hemorrhage. If there is a tumor, there's a small risk that you're gonna kind of spread tumor cells. You can puncture a ventricle, very rare, or you could cause rupture of the tumor. So the next procedure we'll talk about is an abdominocentesis. So here's just a couple pictures. There's radiograph, decreased serosal detail in the abdomen, and then some ultrasound images of free fluid, FF, around the bladder and the body wall, and around the liver lobe as well up here. So indications for an abdominocentesis would be things like, you found free fluid, you want to know what it is it blood, is it septic, things like that. In patients that have liver failure, PLEs, things like that, sometimes you will want to remove that ascites if it's kind of compromising their ability to breathe, or if they're hypotensive or something like that. So your right-sided heart failure patients, things like that. A contraindication would be something like a coagulopathy. This is not going to be as life-threatening as your pleural or pericardial effusion. So usually you have that option to kind of not evaluate the fluid. But again, if you're concerned for sepsis, you definitely want to sample the fluid, get it analyzed so you can properly treat the patient. So the materials needed are listed there. You can use different size needles. Again, depends on the size of the patient. Over the needle catheter is typically what I will use, and then your syringes and whatever tubes that you need, and then your collection system. If you're removing a large volume, so that would be like your chronic right-sided heart failure patients that are getting a large volume of ascites removed. So you want to place the patient in lateral recumbency. They can also be in sternal recumbency or standing. So the positioning is kind of dependent on where the fluid is and clinician preference, as well as what makes the patient comfortable. You're going to clip and prep the ventral abdomen, and then you can also use your ultrasound if you have one to kind of guide the needle. And then, if you're not sure where to go, if you're going blindly, you can insert a needle or a catheter just cranial or caudal to the umbilicus, about 1 to 2 centimeters to the right of midline. So you can do like a closed technique or an open technique. So a closed technique would be where your needle or your catheter is attached to the syringe before you put it in the abdominal cavity, and the open is where the needle is just not attached and you're going to let the fluid drip out. If you're not getting fluid, you can kind of readjust your needle or your catheter to try and get that pocket. And then if you're still not getting anything, you could try a 4-quadrant tap, which is where you would basically just do 4 open needles into the peritoneum. Obviously, the patient's going to be standing for that, and you do 1 in each quadrant around the umbilicus. Once you get the fluid, you want to save samples for analysis. So here's just where you would do your 4-quadrant tap. 1, 2, 3, 4 on either side of the umbilicus, and then there the patient is standing. So the fluid is just going to drip out. So once you aspirate the fluid, you can kind of analyze it. So is it a transudate? Is it a modified transudate? Is it an exudate? So that chart there just kind of goes through those findings. So your transudates are going to be low protein, not very cellular. So things like venous congestion, right-sided heart failure, fluid overload would result in a transudate abdominal effusion. Your modified transudates are going to be kind of medium cellularity, medium protein, and that is going to be more of the kind of the more common that you're going to get. So we can see that with sepsis, we can see it with heart failure, chylous effusion, but then also your exudates can also be caused by those things. So that's why it's important not only to look at the protein level and ideally send it to a pathologist for fluid analysis, but you can look at the PCV. Is it bloody? Is it actively bleeding? You can look at it under the microscope. Are we seeing bacteria? Are we seeing white blood cells? Anything like that. If we're worried about a uroabdomen, we can compare the creatinine and the potassium in the fluid to that of the peripheral blood. So there's a lot of different things that we can analyze. For sepsis, looking at BG and lactate of the fluid compared to the periphery. So again, that's kind of the main reason for an abdominocentesis, at least in the emergency setting, would be to figure out more of what's going on with the patient and how can we direct therapy. So the next procedure we'll talk about is a thoracostomy tube placement or chest tube placement. So this is obviously going to be your larger bore chest tubes. It looks like it's being placed surgically. So I'll go into those a bit, but what we do most commonly in the ICU is going to be our low profile Mila chest tubes, which I'll talk about those too. So this is helpful. Chest tube placement would be helpful for if you're needing frequent, intermittent, or continuous evacuation of the pleural space. So your pneumothorax that you have to tap more than once, or pyothorax, anything like that where air or fluid is going to keep reaccumulating. They can be placed under sedation, like the low profile chest tubes I just mentioned, or general anesthesia. So again, those would be some indications there. Contraindications would be like a relative coagulopathy, again, kind of weighing the risk-benefit ratio. So this is one of the low-profile Mila chest tubes that comes in a little kit. So depending on what type of chest tube you're placing, that'll depend on what materials you need. So those are things listed there: a small surgical pack, suture material. You may need a clamp if there's not one in your kit, your three-way stopcock, your ejection caps, things like that. And so the non-invasive surgical method is also fairly common, so that the patient needs to be sedated or anesthetized for, and they're going to be in lateral recumbency. So you're going to kind of prep the whole kind of lateral thorax. And then these are the chest tubes. They're going to come with a stylet. So typically we'll do a lidocaine block and then a small stab incision over the thorax at the widest part, usually the 9th to 10th intercostal space. Then you want to have someone stretch the skin cranially to create a tunnel, allowing the chest tube to be placed into the 7th or 8th intercostal space. And then you're going to bluntly dissect into the pleural space using hemostats. And then once you're in the pleural space, you're going to spread the hemostats and then allow the chest tube to be passed through the hole that you created. So once the chest tube is in place, then you're going to move it forward about 1 to 2 inches with the tube kind of parallel to the thoracic wall, and then feed the tube off the stylet cranioventrally. If the patient is under anesthesia, you want to stop your positive pressure ventilation while you are going into the chest cavity. Then you're going to hook up your extension tubings and things like that, and then aspirate your sample. This is going to be important where you're going to have to clamp off the chest tube when you're done aspirating, and then typically we'll secure it with a purse string and then a finger trap as well. Once the chest tube is placed, then you're going to take 2 orthogonal radiograph views to confirm that you're in the right spot. So the trocar method is not used as commonly anymore just because there is a higher risk for iatrogenic trauma. And it's never something that you want to recommend in cats because of their small size. But for this one, you want to incise just the skin, and then you tunnel the tube subcutaneously 2 to 3 rib spaces cranially, and then the tube is turned perpendicular to the chest wall, and you kind of grasp the tube in a tight fist, kind of choke up on it, and then you bluntly strike the top of the tube with the palm of the hand and pop through into the pleural space. So it's very scary the first time you do it, but once it's in there, then you lower the tube and then kind of slide it forward as you do the traditional non-invasive chest tube, and then slide the tube off, clamp it, and then aspirate as with the other chest tube. So here's a picture of the trocar method. He's going perpendicular to the chest wall and then kind of choking down it here, popping it in there, and then advancing it parallel once he gets into the pleural space. For the Mila chest tubes or the low profile chest tubes, these are ideal for air or fluid that's not very purulent or thick. A lot of times though, just due to cost, like if an owner can't afford like a full thoracotomy for like a pylothorax, we can at least try with the low profile chest tube because you can kind of flush in saline to try and flush out the chest cavity. But if the fluid's very thick, this is probably not the best option, but for air, it's great. Typically, they only need to be lightly sedated, whereas the other two procedures, you're going to generally want them under anesthesia. So you're going to clip and prep the area just like a regular chest tube placement. You can do a local block if you'd like. The technique is the same as for the jugular catheter, so it's a Seldinger technique. So you basically use like a regular over the needle catheter just as for normal thoracocentesis. So you go into the chest cavity wherever you need to. So if it's air, again, dorsally between 8th and 9th. If it's fluid, ventrally, or wherever the pocket is. Once the catheter is into the pleural space, then you remove the stylet and then you feed a J wire through the catheter into the pleural space. You're going to hold on to the J wire as you take the catheter out over it. So again, kind of like the guide wire and the central lines, you never let go of that. So the catheter is out, but the wire is what's in the pleural space. You can use a dilator. You don't always need to. It's helpful just to get the catheter in if you do use the dilator, which is why you may want to kind of do a small skin incision before placing the first tube. That way the dilator can be more easily advanced. And then the dilator again is just going to dilate the vessel, or there's no vessel really, just the sub-Q space. So once it's a little bigger, you remove that and then insert the chest tube over the J wire, just as for the central line, and then the J wire comes out. So the chest tube is now in the pleural space. So once it's in space, and once it's in place, there's like a Luer locker adapter, and you can secure that by just suturing that to the body wall. And then again, you want to take your x-rays to make sure you're in the right spot. So here's a picture of that. So this is the J wire, and then they're inserting the chest tube over the J wire, and that'll eventually be what goes into the dog. And then once it's in, that's kind of the Luer locking adapter that they use. So it's just a suture on either side, and then you can aspirate your fluid that way. So some complications, as with the thoracocentesis, you can get a pneumothorax, there can be hemorrhage. We can see some subacute edema, especially in some of the kind of more invasive ones like the trocar or your traditional chest tube. When you're tunneling it under the skin, you can get some subacute edema. With the trocar method, you can definitely run the risk of impaling something important like the heart of the lungs. If you are too far caudally, you could penetrate into the abdominal cavity, and also like pulmonary contusions are possible too if you run into that. So with a chest tube in place, you really need 24-hour monitoring. If they get pulled out, you can introduce air into the chest space, give them a pneumothorax. It's just very dangerous. So you definitely want to have 24-hour monitoring. The tubes can be aspirated intermittently. So depending on how much fluid or air you're getting, that could be hourly, it could be every 3 hours. Or you could connect it to a continuous suction system. So rather than having your nurses in there every hour, hooking it up to the continuous suction system will definitely save some of their time. And again, that kind of depends on how much is being produced. The tube should be clamped anytime you're not using it. So that's going to be important to stress to staff who's handling the tubes. And then if you are using a MILA, they have the lure locker adapter as well. So you want to make sure that's all turned off and clamped. And whenever you're handling the chest tube, you want to do so as sterilely as possible. Definitely check the insertion site daily. Has it moved? Is it red? Is it swollen? Anything like that. If you are running into like getting negative pressure, but the patient is dyspneic, definitely recheck an x-ray. You'll find sometimes they've moved. Maybe you need to adjust the tube. Sometimes it can be positional. So there's a lot of troubleshooting that can be involved. And then as far as when to remove the tube, that's typically when you're getting less than 2 to 4 mils per kick per day of fluid. And then if you do have one of those larger chest tubes in place, being mindful to keep the patient on pain medications as well. So here's a picture of one of the bigger chest tubes. They've got a little stockinette on there. It's covered with a tegaderm. Everything's clamped off. But again, just a lot of nursing care that goes into these. Here's a picture of a continuous drainage system. So this would be like a Pleurovac. You can also make your own here. But basically that's just going to be a way to kind of trap air and continuously pull air off the chest. And you do need like a suction unit on the wall for that. The next procedure is going to be a nasal oxygen catheter. So this is going to be similar to the nasogastric tube, but a lot easier because you're not trying to go into the stomach. But this is a lovely Labrador with a nasal oxygen catheter. So securing it again on the lateral side of the nose like an NG tube. And you can go right up the bridge of the nose, or you can go around the side of their head, but it's going to be probably secured there and maybe back there as well. So this would be helpful for oxygen supplementation in any patient. We typically use it if we have a large dog that's not going to fit into an oxygen cage, or if we run out of oxygen cages. Sometimes we'll switch to nasal oxygen catheters. Some patients just really hate being in the oxygen cage, and they do much better in a run with a nasal oxygen catheter. So there's just a lot of reasons that we might use this over a cage, but I would say space and size of the pet are the most common reasons that we would reach for this rather than just putting them in the oxygen cage. It's pretty easy, fast, cheap to do. So again, you can also, you can go around the patient and examine them more thoroughly rather than, in the oxygen cage. You open the door, all the oxygen comes out, they can get dyspneic pretty quickly. And then you can also get pretty high flow rates of oxygen as well, or high fractional of inspired oxygen rather than you can with just the regular oxygen cage. So some contraindications would be things like nasal tumors, rhinitis, nasal fractures, epistaxis. Some dogs just really don't tolerate it, so that may be a disadvantage to some of the other options. But here are the materials needed. Again, proparacaine for the nose, suture material, and then red rubber catheter or an infant feeding tube is typically what we'll use. So the sizes are listed here: 3.5 to 5 French for your smaller patients, 5 to 8 French for your medium, and then 8 to 10 French for your larger dogs. So once you've selected the tube size, you want to pre-measure to the medial or the lateral canthus of the eye and then mark the tube. Then you're going to have someone restrain your patient and then aim their nose towards the ceiling. You're going to give the proparacaine, lubricate the red rubber, and then in dogs, you want to go dorsal and medial initially, and then ventromedially, and then in cats, it's going to be ventral medial. Although I don't think I can ever recall having done this in a cat. But then you're going to kind of insert it just a little bit at a time to wherever your pre-measured level was, and then suture it, like I mentioned, just as you would for the nasogastric tube. Definitely placing an e-collar so they can't paw at it and unhook it and then hook them up to the oxygen tubing. So some complications pretty rare, but you can cause some trauma to that nasopharyngeal area, especially at higher flow rates. So that's why it's important to have a humidifying oxygen source for these. You can also have some gastric distension, some nasal discharge, or epistaxis can also occur. So the last procedure would be urethral catheterization. So these are obviously our blocked tomcat pictures here, which is probably the most common emergency critical care case of urethral catheterization that we see. But we also place urethral catheters in dogs, males and females, either for patient comfort, if it's a big down dog, so they're not urinating on themselves. Any patient that has stones or is blocked for whatever reason, patients that have a uroabdomen will place a urinary catheter to keep their bladder empty. Sometimes we can avoid surgery that way, allow the bladder to heal on its own. Those would be kind of some of the more common reasons. And then again, to like measure ins and outs for acute kidney injury. So there's a lot of indications for urethral catheterization. There's really not an absolute contraindication. Some people might think like a bladder rupture might be a contraindication, but that's actually when you need to get some type of catheter in there to keep the urine from further collecting, but you may eventually need surgery to place that, but there's really no contraindication to placing a urethral catheter. So there's several different types of catheters depending on the species, male or female, but you can use a red rubber, a tomcat, a slippery Sam, a Foley. The sizes are listed there. Again, it's going to vary depending on species and male or female. The length of any bladder catheter should be kind of aimed to end at the tip of the trigone. So closed selection systems are going to be preferred. So that's going to facilitate just kind of sterile emptying of urine from the bag so that you don't have to disconnect it, so you're not getting urine everywhere. It's also going to prevent retrograde flow of urine from the bag into the bladder, which is not good. Open collection systems are not going to be ideal just because you're going to have to disconnect the tubing and everything. And so then the system's open. So that's a chance for bacteria to go up the system. So that's not ideal. The closed collection system is going to be preferred. For male cats, unblocking, you can do a coccygeal block with 2% preservative-free lidocaine. It's fairly easy to do. You place the patient in ventral recumbency, surgically prep the area, and then palpate the space between the sacrum and the first coccygeal vertebrae as it moves when the tail is moved back and forth. And then you insert just a 25 gauge 1-inch needle at kind of that midline area until you hear the pop. As you penetrate into the spinal cord, you're going to attach your syringe, get negative pressure, and if you don't get blood or fluid, then you infuse your lidocaine into the epidural space. So that can be helpful, especially in your difficult unblockings. I would say we don't do this commonly. If we do this procedure, it's probably more like an intern is interested in learning it. But I do think it would be helpful in more cases. It's just not something we rush to right away, but it's definitely helpful. So supplies are listed there. We typically like the slippery Sams, but I've certainly, when I first started out, used red rubbers and tomcats and all of that. But there's several different catheters available. Typically we'll have a lac pack, sterile gloves, all in these little kits kind of pre-made. So the procedure is kind of listed out there. You're going to place the cat in dorsal recumbency. If you need the hind limbs drawn cranially, that can sometimes be helpful. You're going to kind of clip the prepuce, determine how long the catheter is that you need, extrude the penis, flush everything, sterilely prep, and then you just attempt to pass the catheter. So typically you want to try a red rubber or slippery Sam first. If that's not working, you may need to go to something more rigid like your tomcat. It's helpful if you extend the penis caudally so that it will help the catheter advance. And then you can have an assistant kind of flushing the catheter as you attempt to advance it. Sometimes that'll flush out any debris. And if you do use a Tomcat initially, I typically always replace those with a red rubber or a slippery sand because they're not as irritating to the urethra. So retropulsion can be super helpful in these cases, and that's basically where you're going to be flushing sterile saline into the bladder as you attempt to place the catheter to kind of relieve whatever obstruction there is. So there's a couple of kind of tips there. You can occlude the tip of the penis around the catheter so that flush doesn't come back out, and that happens commonly. But just be aware, like, of how much you're flushing. You definitely don't want to over distend the bladder. You can also have someone glove up and occlude the urethra by placing a gloved finger into the rectum or a vagina in a female and then push down on the pelvic floor. So that can kind of help if there's an obstruction in that area. You just kind of quickly inject your sterile saline, and then as soon as you feel the urethra dilate, you abruptly remove your finger. And sometimes it works nicely, sometimes it doesn't. Sometimes the patient needs to be fully anesthetized, especially like female dogs that are blocked. It's just helpful to have them totally relaxed. So once your catheter is in place, you want to secure it. For your male cats, the slippery sand, I think, is the easiest to secure because it just goes directly. There's holes, you directly suture it to the prepuce. If you use a red rubber, then you're going to have to use stay sutures and butterfly tape, which if they're urinating around the catheter, the tape gets all gross and it's just a lot more cleanup. And I've definitely seen both come out. Rubbers, I feel like, tend to come out more frequently. And then you also want to secure the catheter to the tail with some tape. Save your urine sample, flush the bladder, and then attach your closed collection system. And then you don't want to forget to take a radiograph when you're done to make sure not only that your catheter is in the right spot, is it too long, is it too short, but also that's a good time to screen for uroliths. So here's some pictures of the slippery sand being sutured to the prepuce here, and then the red rubber with the butterfly, which again, if they're urinating around that, it can get quite gross back there. So some complications would be things like urethral damage. So urethral rupture definitely occurs. You typically always warn owners that that's a risk. You can get urethral stricture, bladder rupture, renal damage, detrusor atony, or urethral spasm can all occur. For females, female dogs are pretty tricky to catheterize. Female cats actually not as tricky as you might think, but there's several different methods. Typically, we're going to be trying to use a Foley catheter in females. So for that, you're going to need your sterile lubricant, your catheter, and then your sterile syringe with water to inflate the Foley balloon. You could also use a red rubber catheter as well if you don't have the Foleys. So again, you want to sedate the patient, especially in a female dog. They can be in either lateral recumbency or sternal recumbency with the legs off the table. You want to kind of clip around the perivulvar area, flush everything out. A lot of people like to use sterile lidocaine jelly into the vestibule. If you're going to be using like a speculum or an otoscope cone, you don't want to use the jelly because you're not going to be able to see much. If you are using the Foley, you want to make sure you test it, make sure it works, and that the stylet can be removed. And then you want to measure and do your marking on the catheter length so you know where to stop once you get the catheter in the bladder. So again, before you insert the catheter, you want to lubricate it. And typically, we'll also do a palpating finger. So the palpating finger, and this is going to be for dogs, so female dogs, going to be between the labia of the vulva, and then depending on how big they are, you may be able to feel the urethral papilla, but if not, you can just kind of leave your finger right there, like at the insertion of the vulva, and then you want to do the catheter ventral to the finger and then advanced into the bladder, into the urethra and the bladder. If you're not getting urine, You want to make sure that the catheter is in the right spot. A lot of times it will like pop back out. So it can be very tricky, and a lot of patience is needed, especially for the dogs. So once you get the catheter into the bladder, you inflate the Foley and then pull back until you meet resistance, and then take your confirmation radiograph. So a couple of tips and tricks we listed out there. So you kind of line up the catheter along where you think the urethra should be. You want to aim the catheter tip downward. You can try placing the patient in right lateral recumbency if you're right-handed. If you do pull up on the tail, that can make the vulvar opening more narrow. So we typically don't like to do that. And then just for palpating, once you insert the finger into the vulva, you can kind of turn it horizontally and cranially so that you're at the vestibulo vaginal junction. That can be helpful as well. And then you want to kind of feel again for that urethral papilla. You can also use a speculum or an otoscope cone, but if you do that, you're probably going to need to have the patient pretty sedated. But you can just kind of insert that into the vestibule, and you're going to try and visualize the urethral papilla. So for female cats and smaller dogs, that's going to be a little bit different. In cats, the urethra is going to open on the floor of the vestibule. So again, it's a little easier to catheterize, but it's not like the easiest thing in the world. But typically we'll put these patients in lateral or dorsal recumbency with their hind limbs drawn cranially. And then you want to pass the catheter between the dorsal aspects of the labia, going towards ventral midline and towards the bladder. For male dogs, it's going to be easiest out of all of those that I just talked about. Typically, sometimes it can be challenging if there are stones or a mass or something there. But basically, you want to shave around the prepuce, extrude the penis, sterilize everything, flush everything, make a note of where your catheter should end. And typically, again, we're going to be using Foleys, but we'll often just pass a red rubber to empty the bladder. And the down dog if we don't want to go, with the full Foley. But definitely want to measure, see how far you're going to go. And then insert the catheter through the penis. You may need to retropulse, as we talked about for male cats, but typically the male dog urethra is larger, so it's much easier to catheterize. Once you have an indwelling urinary catheter, you definitely want to keep a close eye on it, inspect it and the collection system often for signs of soilage. You want to make sure your connections are secure. You also want to keep the bag lower than the patient level, obviously to encourage retrograde flow of urine. We typically will empty and quantify urine output every 4 to 6 hours or more frequently if needed. And when you're doing that, you want to wear gloves. For azotemic patients, we definitely want to match the ins and outs, especially in our obstructed kidneys. They can get a pretty profound post-obstructive diuresis, so their fluid rates can be very high. You want to perform catheter maintenance about every 8 to 12 hours, or whenever you can see, like if they're urinating around the catheter or it looks soiled. Obviously, you're going to need to do that sooner. And then we typically use surgical scrub and then a saline rinse to clean the area. So that's all I've got for you guys. Those are some references that I used.